Good evening, everyone. My name is Tanya Winders, and I'm the President and CEO of Allergy and Asthma Network, the host of tonight's PBL webinar, Post-COVID Using Inhaler Use Data in the Management of Respiratory Disease in the Era of Telehealth and Social Distancing. We're excited to have you all here with us for, actually, this is part 2 of a problem-based learning interactive case discussion that we held the first one about 4 weeks ago. Tonight we will be recording, and so we'll ask that all of your lines will be on mute until we get to the end of our presentation, and then we'll actually, if time allows, open the line and ask any questions. You also can use the control panel in the right-hand side of your screen to enter any questions at any time throughout the presentation, and we'll try to field those at the appropriate time as well. We do not offer continuing education credits for tonight's PBL webinar. However, we do offer a certificate of attendance, and you can download that as well in the control panel at any time throughout our time together this evening. Again, we appreciate your time and engagement tonight. And at this point, I would like to thank Teva Pharmaceuticals for their support of this unbranded educational webinar for healthcare providers. Tonight's PBL facilitator is Dr. Ray Davis, and Dr. Davis is an allergist immunologist in St. Louis, Missouri, and one of the co-founders of the PBL Institute. He will be leading our discussion throughout the evening. Next, we have Dr. Don Buckstein, also a co-founder of the PBL Institute and board certified in allergy pulmonology as well as internal medicine. We're excited to have Dr. Buckstein joining us from Wisconsin. Next, we have Dr. Purvi Parikh from New York. Dr. Parikh is an allergist immunologist at the NYU School of Medicine, as well as in community-based practice in Manhattan. And she's the national spokesperson for Allergy and Asthma Network. And we're excited to get her perspective on the use of digital inhalers tonight as well. And then finally, we have Dr. Vikram Tejwani. Dr. Tejwani is at Johns Hopkins Medical University and is a board certified in pulmonology and has also been on the front lines treating COVID patients in their COVID unit there. So we're very excited to have all of their expertise as we talk about this. I wouldn't necessarily say post-COVID era. I think we're still in the mid-COVID era, but nonetheless, definitely how care has changed over the course of the past 8 months and how it will continue to change and evolve in the coming days. And so with that, I'll go ahead and turn it over to Dr. Davis.
Thank you, Tanya. Thank you as well to Teva for supporting, and we love the Allergy and Asthma Network and all the great work you guys do there. So if we could have the first slide, Tanya. All right, for those who didn't participate or listen in to part 1 4 weeks ago, and even for those who did, this will be a good review of Elizabeth R., who was our patient in the problem-based learning case. So Don, do you want to help us read the first slide just to review her history?
Sure, Ray. During her new patient consultation 10 weeks ago over a telehealth platform, Mrs. Elizabeth R., a 64-year-old dental assistant, presented with the complaints of coughing a lot, rattly chest, and out of breath some days. Elizabeth was referred to her primary care physician, Dr. Smith, a colleague, a board-certified colleague in both allergy and pulmonary medicine. Elizabeth reported having recurrent respiratory problems over the last 6 to 7 years and 4 or 5 urgent care visits for what was termed reactive airways over the last 2 years, needing oral steroids and antibiotics each time. Prior to her initial visit 10 weeks ago, Dr. Smith's nurse assessed in a network pharmacy documents which showed that Elizabeth received a 3-month supply of her inhaled steroid LABA and 3 short-acting reliever medication, rescue inhalers, as part of her 3-month refills.
Thank you, Don. Tanya, can we have the next slide, please? Vic, you want to help us out going through what we found out 4 weeks ago about Elizabeth's test results?
Of course, yep. So 4 weeks ago, Elizabeth's test results, she had skin testing, which showed positive reactivity to both dust mites as well as ragweed. Her ACT or asthma control test score is consistent with uncontrolled asthma at 15. She did spirometry with adequate technique and did have bronchodilator reversibility meeting criteria for asthma. And inhaler technique, which notably at her initial visit prior to even this one 4 weeks ago was excellent, was now reassessed in lab and shown to have poor technique. She was retrained at that time. Her oxygen saturation was 98%, and she had an absolute eosinophil count of 200 with an IgE count of 58.
Thank you, Vic. Can we have the next slide, please? All right, Purvi, you want to read the Dr. Smith's interpretation?
Sure. So after evaluation, Dr. Smith diagnosed Elizabeth with severe uncontrolled asthma. Dr. Smith was principally concerned with whether Elizabeth could maintain proper inhaler technique and if she was truly adherent to her preventative controller medication, her ICS and LABA combination. Dr. Smith was aware of new evidence on electronic inhaler medication use tracking. After a shared decision-making discussion with Elizabeth, they agreed to have Dr. Smith prescribe 2 electronic multi-dose dry powder inhalers for her rescue as well as for her controller treatment.
Thank you. Tanya, can we have the next slide? So we didn't mention at the beginning, but we should have probably, that we really want all of our participants and attendees to answer some questions for us before we go on any farther, and we'll have several other opportunities to get your opinions. So what is your knowledge about inhaler technology that uses electronic medication use tracking? A, I have no knowledge about this type of inhaler technology. B, I have very little knowledge about this type of inhaler technology. C, I have some knowledge about this type of inhaler technology. Or D, I have a lot of knowledge. So we'll wait just
So
about.
the poll is active and we'll collect responses for about the next 30 seconds or so. If you'll go ahead and put in your response, then we'll share with the group the current knowledge of inhaler technology using electronic medication use monitoring. Looks like we've got just about 2/3 that have their vote in. So we'll give it just another moment and then share the results. Thank you all for participating. We will have, as Dr. Davis said, we'll have several of these polls throughout the evening. All right, I'm going to go ahead and close the poll and share. So it looks like at this point that about 29% have no knowledge of this type of inhaler technology currently. 39% have very little knowledge, 26% some knowledge, and then 6% that are ahead of the curve with a lot of knowledge. So it looks like we've all got a lot to learn when it comes to electronic medication use technology tonight.
Thank you. Thank you, group. Okay, so
Time for our next
question.
poll already. Yep. So do you have any experience?
Okay, go ahead.
Sorry, using an electronic inhaler technology to monitor patient inhaler medication use in your practice? Yes or no? So once again, if you'll go ahead and enter your result. Have you actually prescribed these or used them at all in your own practice? Leave it open just a moment longer. Right. And we'll go ahead and share the results now. So it looks like that the vast majority, 94%, have not currently had any direct experience utilizing this. Are we ready to move to the next slide, Dr. Davis?
Yes, please.
All right, one more poll question here. In your opinion, what is the most important information that a digital inhaler report should provide to patients and their healthcare professionals? Day-to-day use of controller medication or adherence information, day-to-day inhaler use technique, overuse of rescue or quick relief medication, or I don't see a need for digital inhaler reports. So we're going to go ahead and launch this poll and get you to respond. It's open now, so go ahead and cast your responses. Again, the most important. So we know that all of these may be important to you, but what would you say is the most important response? Those responses are quickly coming in. We'll leave it open just another moment or two. And a lot of variety in the answers. We like that. All right. With 3/4 of the individuals on the line voting, I'm going to go ahead and share the results. Looks like that we've got day-to-day use of controller medication or adherence as the #1 answer with 52%, overuse of quick relief or rescue medication at 32%, and then day-to-day inhaler use technique as 16%. And thankfully, no one on the line responded that they really don't see any need for this technology.
Okay, so there are two major digital inhaler platforms that have been in use, one being integrated and one being add-on digital inhalers. And the next couple slides will go into a little bit more detail, but they are both attached via Bluetooth to a mobile app that the patient can download, and it goes into a cloud-based platform. The data is all collected and can be exported. Patients can provide this information to their healthcare professional either by printing it out or can share it on an internet dashboard if they want to on a regular basis or just at visits. And let's go on to the next slide, please. So this shows that this is one type of electronic inhaler tracking device, and it's so-called add-on sensor that can be used somewhat on multiple different inhalers once the inhaler medication runs out. It can attach or wrap around the top of the inhalers. You can see it records a time-stamped use data, and the accompanying app provides controller medication reminders as well as reports about environmental and weather conditions. Next slide, please. And the other type is called the so-called integrated sensor, where it's just inside each inhaler and you don't have to take it off when your medication runs out. It comes with the inhaler each time you get a new one. The device is built in, as I said, and data is time stamped every time it's been in use. That information is captured on the app, as you could see. Peak inspiratory flow rate is actually tracked, and actually inhalation duration is also looked at and documented. I already mentioned before that it's by Bluetooth technology, which seems like every app is these days, and the app as well for the integrated sensor provides controller medication reminders as well as reports about environmental and weather conditions. Next slide, please. So Don, do you want to help us with the follow-up visit for Elizabeth R. 10 weeks later, bringing us up to the current period of time?
Elizabeth R. Is going to follow up. Dr. Smith made a follow-up in 10 weeks, and she was reluctant to even return to Dr. Smith's office during the COVID pandemic and requested another virtual visit instead. A 10-week follow-up visit to Dr. Smith over a telehealth platform, the nurse provided Dr. Smith with a fax copy of Elizabeth's last 2 months of both her EMDI inhaler utilization and she responded to an ACT questions filled out by the RN for Dr. Smith. Currently, her ACT was 23. If we all remember back a couple slides when she came in, initially it was 15. She reported that she feels like she's taking her new preventative inhaled steroid LABA inhaler more frequently, is using her rescue inhaler much less. Her respiratory rate appeared over the telehealth platform, 14 breaths per minute, and she had no coughing or wheezing while Dr. Smith was talking to her.
So Vic, let's go back just for a second, Tanya, before we get to the report.
So sorry. Yep.
Vic, what are your thoughts about her follow-up visit?
Well, yeah, I mean, I think as we kind of might have extrapolated from the last visit, once we corrected that technique, the use of the ICS, the long-acting LABA, she definitely seems to have much better control. And I think certainly, I mean, I'm excited to see the next slide and what the digital monitoring looks like. But based on the ACT score alone with the 23, I think at this point you're feeling like she is in a really good place based on that score.
Purvi, any additional thoughts?
No, I agree completely. I mean, we have data that shows even with perfect inhaler technique, only about 60 to 70% gets to the appropriate areas within your lungs. So imagine what it would be even with poor inhaler technique. So, I completely agree with Vic on all those points.
Okay. So let's keep in mind that she feels she's doing so much better, and she reports an ACT of 23 compared to 15 previously. So let's just keep in mind that now she thinks her ACT is close to perfect. Don, you had a comment?
Yeah, I just think this is a wonderful example of how the telemedicine digital health is really going to be here to stay. Here's a lady who didn't really want to follow up, but ease of use of her medication really made her follow up much easier.
Yeah, thank you.
Right, and the other nice part is we can still use objective measures even over telemedicine, which is sometimes a concern, like the monitoring.
Right, and it's really active involvement, self-directed kind of care, and a lot of people really, especially if you use shared decision making, which Dr. Smith did to introduce it, they become activated, and it's going to be helpful in not only activating them to get them to do it in the first place, but sustaining and motivating them kind of to do it in the future. Also, it probably is going to be a good forum for now the nurse to make sure she hasn't had inhaler decay, where she's, she wasn't using her inhaler very, as Vic said before. Now, how's she using her inhaler? And we found it really useful in days of masks. When they come into the office, they're wearing a mask. And it's hard for the nurses to do inhaler technique and still feel safe and have the patient feel safe. Whereas at home, she can grab her inhaler and her daughter's there and maybe a friend or whatever, and you can go over a teach back and use your inhaler. And it actually sometimes online over a telehealth visit is easier than it would be even in the office, especially in the COVID era.
Okay. Can you have the next slide, please, Tanya? So this is probably a little bit hard for the audience to see, but this is what an actual report would look like from an electronic multi-dose dry powder inhaler. The patient, as I mentioned earlier, can print it out or export the information as a PDF file to their healthcare provider. The report contains self-assessment icons, which are at the very bottom, but we'll see on a close-up as we get to the next few slides, you'll get to see that. And the report also contains important safety information about any product that is prescribed. So as you can see, this report at the very top has some little look like black and gray dots or lines, and then some colored lines, multicolored lines underneath, and that will represent the controller therapy, which we'll see close up momentarily. And then the bottom half of this report contains a short-acting rescue medication use. And again, on the top graph, you'll see any number of different uses when she actually used her rescue inhaler. And then the very bottom are again multicolored dots that basically show when she used her inhaler, time stamped, what her technique was. Was it very good? Was it average? Was it poor? Or did she blow into it? Or is it possible the vent closed? So if we can have the next slide, please, Tanya.
Yeah, just real quick before we go to the next slide, Dr. Davis, we do have one quick question about, for Elizabeth specifically, add-on or integrated digital inhaler. And then second question, do the add-on digital inhaler technologies actually work with DPIs?
Anybody want to address those questions? Your first question was,
is Elizabeth in the case actually using the integrated or the add-on?
Yeah, I think in this case, Ray, she's probably using the integrated inhaler. The add-on doesn't measure, usually the add-ons don't measure inspiratory flow or inspiratory rate, and don't give, they're more of an adherence tracker than they are actually giving you information about the inhalation technique. And the way it works, the inhalations less than 30 liters a minute get put in as poor, and in between 30 to 45, you know, they're okay, but over 45. And I doubt whether it's a dry powder inhaler. Obviously, it probably MDIs, but it may be MDI that has a dry powder in it. It's but not a patient activated. It's activated in some way by itself or by the patient's flow. In other words, the patient has to suck in the inhaler to breath activated to get it to work. So I think that answers the question, that it is a breath activated inhaler. And in those breath activated inhalers, I might say there's a lot of research. It's really interesting that breath activated inhalers tend to be easier to reteach people how to use them. I think studies show both MDIs and dry powder inhalers or breath activated inhalers kind of at the first time are about the same, but reteaching is easier. And the other thing is that, you know, it's interesting that a study done a while ago showed that groups that have patients, that if somebody's in a big group where they see a different person each time, their inhaler technique is much poorer than somebody that has a consistency of going back to the same physicians and same nurses. So there's a consistency to watching a person do it or having digital feedback on a person over a period of time.
Tanya, if we could have the next slide, please. All right, so here for the audience is the close-up of the top half of the report. And I think you can see a little bit more detail that with this controller inhaler, which is a dry powder inhaler, breath activated, which is an ICS LABA, so it's a combination, that every dark bar in the top graph represents an actual inhalation over a 3-month period of time, and it gives you 3-month clips. Every gray bar was a missed opportunity for the patient who was due to take the second puff, since the dose is 1 puff twice daily. So you can see there were a number of gray bars where those doses were missed, some complete days, others where maybe only 1 dose was given that day. And it basically tells you the day of the month and whether it was the morning or the evening dose. As you can see from the bottom part, the graph, it's color coded each dose that was taken, whether there was good inhalation in green, which means, as Don said, more than 45 liters per minute inhalation, and whether there was kind of a light pale green, which was fair inhalation, 30 to 45 liters per minute. And in the red, whether there was low inhalation, less than 30 liters per minute, or no inhalation at all that was done adequately. The purple represents exhalation into it, which we hope none of our patients after we teach them would do, but it's still possible. And 4%, if 4% of the time in this particular case, in Elizabeth's case, there was a possible block of the vent when she used it. So once again, you can kind of see if you tabulate everything, what you see is that with Elizabeth, there were only 21 days when Elizabeth used the full dose BID. There were 36 days when only one inhalation was used and the second one was missed. And there were actually 20 days without any inhalation of her controller medication over a 77-day period. What are your thoughts, panelists, about?
I want to point out one other thing, Ray. Can
Okay.
I?
Sure.
If you look at day 17 or so, you see a little X or a star, or yeah, I forget what it is, right there. That means that on that day, she actually used her controller more than the 2 times a day. And that's important because we have a lot of what's called smart therapy now, where with controller medications, you may be using it once a day regularly, but some days, if you're not doing as much as well, you'll use it twice a day. I use that myself, and during certain part of the year, I use my combination therapy twice a day, and other parts of the year once a day, and I'll use it here or there. I know about these because I have one like this that I use, and that's why I just wanted to point that out. That,
okay. So yeah, so that is a good point, although it's really hard, I think,
hard
to see that
yeah.
there's a little, I'm not sure exactly what that is. It should be like a little star or something that at the top that shows that more than 2 inhalations were taken on that particular day. Too bad she couldn't have just taken it twice a day all the time, but
yeah,
that's just not the real world.
And that may be important because now a lot of people with their LABAs that are quick acting inhalers will use it if I don't have and I usually don't, my reliever nearby, I'll obviously use that as a reliever.
Okay, so what are your thoughts about her adherence? She reported she was adherent much more than she had been previously with her new medication, yet look at what her adherence is. So what are your thoughts, panelists?
Yeah,
well, I think this is very realistic. I was just going to say, from a patient perspective, I mean, this is realistic. If they are taking it more than half the time, then they think they're taking it like they should, even though we know that it's not perfect. So I do think that it's that patient perception, and oftentimes they overestimate their level of control as well as the frequency of use of their medication, and they underestimate the impact that that asthma is having on their daily life. And so it's the very common story that we hear from so many patients.
Exactly. Yeah, and I think completely agree regarding the realism of this case, Tanya. And I think before, this data is wonderful, and I think outside of data like this, what I'll usually do is look to the patient's spouse or family member that's at least before COVID was in the room with them to say, wait a minute, tell me what's really going on here. And this is kind of nice to have all of this. And I think just highlighting that, certainly having an integrated inhaler with the bottom row and getting a little more information on technique is wonderful, but there's actually just so much information with just what you would get with the add-on inhaler. Looking just, is she using it regularly twice a day or not?
Purvi, any thoughts additionally?
Right. No, I mean, I completely agree. This basically just shows what we already knew. Most asthmatics who think they're controlled are not, even ones that are on daily controller medications. And, everyone always overestimates their control, their adherence. And, at least now we have objective data that we can show them, because I might even actually believe I'm taking something on a daily basis. And this happens with my own multivitamins. And then if someone actually points out, actually, you missed half of the days, it's actually very eye-opening, I think, for the patient as well, because it might be something they're not even realizing in busy day-to-day life.
And it especially goes well with the telehealth visit, because there you may have her daughter or whoever is there. And then if you have this kind of data that you can pull up and actually show her, if you have it, if she's allowed you to have it, and the patient really has to allow you to have it. But even if the patient has it, you can say, let's look at your data and go through it. And that other person in the room can be that support and motivation in the future to kind of put gentle reminders around to take their inhaler.
So I've been an allergist 38 years and a clinical private practice and teaching at Washington University with the fellows, I've been able to track patients' prescriptions by calling a pharmacy, or my assistant does so, but that still doesn't really tell you for sure what this information does. So for the first time in 38 years practicing, with patients' permission, we actually can have some very important information.
Yeah, you know,
Yeah, I would argue.
I'm sorry, I was just going to say, Ray, to that point, so many times we hear patients, well, I picked up my prescription, you know, well, does that actually mean that you are using it? Or even if it does happen to have a dose counter, which always isn't the case, sometimes we'll find that, you know, just if they know that you're going to be checking that dose counter, they might actually actuate a few times without inhaling. And so I just think that there's many different ways that prescription data and even dose counters historically aren't as reflective, and this type of information can add an additional level of value.
Yeah.
The other thing,
not to mention patients use, oh, sorry, go ahead. The only point I was going to make is patients use multiple pharmacies. They're now relying on samples. So the pharmacy data isn't as helpful. And then the second side of it too is this actually saves the physician and the physician team an immense amount of time, because now the data is right in front of you. You don't have to call the pharmacist and try to track down that information. So I think it makes it a lot more seamless for both the patient as well as the provider.
More accurate and less time.
Right. One of our past Surgeon Generals said, medicine won't help if you don't take it. I think that's a very wise thing. And here we're for the first time being able to get some insight in what their inhaler technique is like. And we know that there's this decay in inhaler technique in many patients, that patients use their inhalers bizarrely at times or not use it at all. So again, I think we're getting insight far more than just the adherence of whether they're using it or not, or using their reliever too much, but actually what's their technique like.
So to your point, Don, that if you saw this patient for follow-up in your office and you were able to check inhaler technique, and maybe she did it better than she did it previously, but as you said, there's multiple studies showing decay in inhaler technique over time with most patients. At least at this point in time, you could review with her permission, the last 3 months, and you could basically say that, Elizabeth, it shows that over 50% of the time you had good inhalation, but you also had other times when almost 20% of the time where either you didn't inhale or you inhaled very poorly, and we really need to make sure you're consistently inhaling it the same way every time, fast and deep, and holding your breath for 10 seconds like you're supposed to. So I think you hit the nail on the head about inhaler technique being so crucial, and this giving us information that we've never been able to have in real time.
So we do have some questions coming in if we want to pause for just a moment and get to some of these, because I know that that's one of the things that our participants definitely want feedback on.
If you feel that this would be a good time, sure.
Yeah, I think some of them are very appropriate. So one, is there an option for the integrated or add-on and and inhaler monitors to bring those reports online? Does the patient actually have to initiate sharing that report? How does that work? Or if you've got patients that are using this technology, do you just automatically get that data?
It's a good question. Who wants to handle that one?
Well, the first thing they have to do is download the app. We like to download the app right in the office with the patients after we do shared decision making, or if it's a televisit, which most of them are now, that presents a little bit more difficulty. You have to do it at the pharmacy, but download the app. We work with specific pharmacies when we're giving these out right now, because we have people there that are somewhat trained that can download the app. Once they download the app, then they have the ability to see the data and to share the data with other people. And you could share it with your physician. You could, I don't think you might not want to share it with an insurance company or someone else, but in the days where we have to have prior authorizations for different things, I see the time coming where this information may be useful to prove that you're taking a medication and that you may need now additional medication like a biologic or whatever. So these these may be very useful to patients, but right now patients are totally in control. They download the app and then they can share it or not share it.
Okay, great. And then the next question just comes in regard to, are you as the panelists consistently asking that your patients also track their peak flow? Does peak flow matter relative to what we're seeing from these reports?
Yes, I think, peak flow is still a very important tool, especially I know a lot of my patients want an objective measure that they can quickly do on their own, especially when they're not sure, am I having an attack? Do I need my quick release medication, or is this just anxiety? Many different things can present like asthma symptoms. So yeah, we always have an asthma action plan. Of course, every child going back to school that I see has one, but many adults also find it very useful, especially in the age of telemedicine.
Yeah, I completely agree, Pervian. Another place where peak flow is also relevant is particularly early on when you're trying to find triggers before the disease is fully characterized to say, oh, if a peak flow drops a particular day or a particular time of day, was that a time when you went out into cold weather, there was a seasonal change or whatever it may be. So I think that it'll continue to complement this, certainly.
See, now I'm an old guy.
That's a great point.
I'm an old guy, and I'm going to tell you, once I remember initiating a study with nursing students, they were going to see how people use their peak flows. And they came to me the second day and said, we have to stop the study. 80% of our people didn't know where their peak flow meter was. And peak flows are fine, and I've gotten people to use them intermittently. But this is so much better because it's actually kind of attached to your inhaler, that you're used to taking your inhaler everywhere, and it's giving you insight like Vic said, am I using my inhaler at a certain time? When I go to my aunt's house, or when I'm around these dogs, or whatever the exposure may be, or an occupational exposure. I find that use of albuterol more interesting than peak flows. And it doesn't take kids about a minute and a half to figure out, if they put their tongue on the end of a peak flow meter, that they can make it go really high. So I use peak flows in certain patients, and mostly the obsessive compulsive kind that still send me their daily peak flows, even though I haven't seen them in 10 years. But all kidding aside, peak flows have utility. It's hard to get people to use them
And do it correctly.
Consistently, yeah.
Consistently and correctly, right? Yeah.
And correctly, yeah.
Yeah.
All right,
I
Dr.
think,
Davis, let's go back to you.
I think this is a good segue, Tanya, into the next slide, which,
Yeah.
as Don was referring to, use of albuterol for rescue. Let's look at the SABA report, and it shows the time for the 3 months from April 1st through the end of June, and it shows in the white color in the center of the graph the daytime, and then the nighttime is the top of the graph in the darker color and the bottom of the graph. So it actually shows when rescue medicine was used, and then at the very bottom it shows color-coded when each dose was used. Once again, was the technique good? Was it fair? Was it poor and very low? Or was it an exhalation into the rescue inhaler? And as you can see from this graph, there was one particular day, and it looks like it was the 19th of April, that Elizabeth used her rescue medicine. As Don pointed out, there's a little star, and I think in red at the very top, she overused. And when you overuse your medication above what you have been recommended, then you get the little star or asterisk in red. And once again, even during that day, it shows that several of the puffs were not taken properly on the 19th there in the color coding, the bottom graph. Yeah, right there.
But you also see that blank circle where it says low or no inhalation.
Right. Well, 20% of her, 20% of her use of the rescue was exhalation into the rescue medication rather than inhalation, and there were only a total of, as it says, 34%. About a third of her doses were good in green. So the other thing I felt was really interesting was at the very bottom, where it shows the little emojis, smiley face or sad face, and they are also color coded, that she had a smiley face right before she had this exacerbation, somewhere around the 17th or 18th, but she really didn't even put an emoji on the 19th, the next day. And that's real interesting that she particularly left off how she was feeling on the day that she used the most albuterol for rescue.
That's what, Ray, that's because our patients love us and they don't want to disappoint us, especially your patients. They come in and say, I want Dr. Davis to like me. And so they have something called the Hawthorne effect that says, hey, I'm not going to say even put something down there because I don't want them to know that I'm not happy today, that I'm not having symptoms. And you can see a day or so before she was all happy and then doesn't put down anything when she's using her inhaler 10 times a day, 12 times.
Yeah.
So as Vic referred to earlier, Don, and Irvi and Tanya, maybe something happened that she can remember that caused an exacerbation, and she would learn from this if she could back it up and figure out maybe it was paying her taxes. I don't know, it was right after the 15th of April, so I don't know. I could give all of us a heart attack or an exacerbation of asthma. But any thoughts, panelists, about this data? Because this is data we've never seen in all of our practices before.
I think it's very helpful because besides just trying to please their physician, we always ignore the kind of psychosocial aspect of asthma, and there's a large element of stigma, of denial, and many people just don't want to be even labeled as having a chronic condition, you know, and they feel like they don't want to be labeled as reliant on inhalers or needing medications, and it's a constant almost battle I have with my patients to try to normalize it because many of them are so resistant to even admitting they're using their inhaler or even using it. So I think this is very telling about that aspect of asthma, and we can't really ignore it because it plays such a large role in asthma control. But it's nice to now have that objective data because it's easy to lie about something or hide something, but this, you know, the numbers don't lie.
Maybe Vic and Purvi and Tanya too. Do you think she's a poor perceiver? Maybe she's honest,
I
but she
definitely
just
think
doesn't feel anything.
Right. I was just gonna say, I think number one, she's a very poor perceiver, especially in the nighttime, right, or in the wee hours of the morning. It looks like that that's midnight to 6 a.m. right. So she's using her inhaler, and even midnight to the different time zones there. So when she's asleep and waking up and grabbing that inhaler, maybe she doesn't even realize that she's really doing that, right? And this, again, has been the problem with patient diaries for decades, that people often forget how many times they're awakened in the night. And what we can definitely say is that her ACT score of 23 on this particular telehealth visit is inconsistent with the activity that we're seeing in this report.
Yeah. So that's really interesting. I know a lot of EMRs have the ACT, and a lot of people, you know, really feel it's been validated and it's so valuable to have the ACT to follow. And now we're looking at this data, and I think this is kind of exciting that I'm not sure how valuable the ACT really is when at least one of the 5 questions is, in your opinion, how good has your asthma been controlled the last month? And how often have you used your albuterol for rescue, both daytime and nighttime? And that makes up 3/5 of the numbers. And she obviously felt she was doing much better than she really was. So this is kind of exciting to me. I don't know. What do you guys think?
Yeah, I mean, I think it's human nature. You know, I mean, people don't remember. I don't even remember, you know, half of the things I did yesterday. It's like it becomes a blur very fast. So it's not even really her fault. It's just very difficult to capture all those moments, especially over a long period like a month.
Yeah, and we mentioned earlier the time of calling a pharmacy. I mean, I think the other thing is Ray, as you said, if they're comfortable sending it to you and you have this ahead of time, I think this also makes your visit with the patient so much more efficient, because a lot of the questions that you have to ask, which are kind of biased, recall bias to begin with, you actually have, if they're comfortable sharing it, have that data ahead of time and can have a much more focused visit. The other thing that I think stood out to me as we all discussed, you could certainly the 19th is an area for discussion and a trigger. And I also think just looking at the last slide, that's also the day that she didn't take her long acting. So it's possible that you have a really remarkable teaching moment here where you could say to the patient, there's a very direct correlation to missing your long acting medication and then what occurred the next day.
Absolutely.
I wanted the
That's a good
I
point.
found those poll questions to be really interesting, and I saw that 52% said the most important one is the controller, 34%, or I think it is 32% said the most important one is the rescue inhaler. I was kind of wrestling with that question myself. I mean, I think as a first pass, I would probably want to know if they're taking their controller medications appropriately, and I also I think patients tend to be a little more Elizabeth aside, a little bit more reliant on the short-acting use. I think that's a little bit more memorable than are they taking something regularly every morning and evening. I'd be really interested to hear everyone's thoughts on that. I was excited to see what the audience thought and was kind of wrestling with that myself.
Yeah, I mean, obviously there's no wrong answer on that one. Somebody could argue, gosh, I want to see if they use their inhaler correctly, because it really doesn't matter if they take their inhaled steroid LABA regularly or their bronchodilator if they don't use it right. So I guess there are a lot of angles you can see. I find this terribly exciting because it really gives an opportunity to go in and do shared decision making about getting this device that leads into other shared decision making about adding on additional. And obviously, if you've got somebody on combination therapy and they're failing, the next step is a biologic. But before that, this gives us insight into other things that we may be able to approach before jumping to an expensive biologic. And if this thing is going to be adopted by systems, it's going to have value. And that means that the better symptom control, the better disease control over the cost of a little bit more time and getting people on the team all orchestrated into your workflow is worth it. And I think in the end, we'll decide that it is for many patients, and maybe some patients it's not. It'll be individualized. But I just wondered what you all thought about that and that value that this brings to the patient and the system and the physician.
Right, it definitely picks up on certain subtleties ahead of time. Like you said, it may save the need for an expensive biologic.
Yeah, and I was just going to say, I mean, Vic, I agree. I mean, it's hard to choose between controller and reliever because both are so important to understanding the full story of this patient. However, we do know that one of the number one signals for mortality or death from asthma is overuse of SABA. So if I had to push come to shove, I would probably want that SABA data and just trying to know which are those high-risk patients that I really have to be concerned about the risk of death from asthma. And I think that it could be a huge benefit for anyone who has an ER visit or a hospitalization from asthma to then be utilizing this type of technology in the month or two thereafter to see how are they using that controller versus reliever ratio.
But Tanya, also, Sammy Sluicy, Saskatchewan, in his study showed that significant underuse of controller is associated with increased death rate. So we got all kinds of things that increase death rate. I'm not going to go to counting the headstones yet, but my question is, does something like this that we see here, does that count as a mini exacerbation that gives you insight that a big exacerbation requiring an ER visit or a steroid burst or whatever is about to occur? I personally think it does, that when you see these mini exacerbations getting more and more, that's a prelude to a more severe, what we term an exacerbation today. I just wondered your guys' thoughts, and Ray.
Yeah, I think that's a great point. It kind of, oh, sorry, Purdy, I was going to say, it kind of lets you pick it up earlier before it gets to that point. So.
Yeah, no, I completely agree. I think for that reason, both points of data are important, because lack of control leads to poor outcomes, and overuse of the rescue medication also does. But we need to know the reason why. Is it because they're not using their controller, or are they still using their quick relief even on top of their controller? Then it's a totally different management story.
So we somewhat artificially asked that question, polled that question to the audience, when the bonus is that all of these things are important and all of these things are obtained on these reports that we get, as long as the patient, through a shared decision-making discussion, agrees and understands how valuable this can be to her as well as to her healthcare provider.
Do you have any other data here, any other slides of data?
I think we have another polling question or two, Don.
Oh, we do. Okay, let's look at it.
Great. So that leads the perfect segue into this polling question. How important is shared decision-making discussion with a patient regarding starting a digital inhaler? And so we will launch the poll and ask you all to share your thoughts. Is it not important, slightly important, moderately important, or very important? We kind of gave this one away before we shared this poll, but I think that everyone is coming up with somewhat the same response as we keep this open for just another couple of seconds. All right, we'll close that poll and share the results. Looks like that universally, everyone pretty much feels like it's very important to
we don't need to say anything, do we?
No, self-evident.
All right, how about our next slide? Let's see, one more poll here. In your opinion, what is the most important information in the inhaler use report? Is it the inhaler technique information, the controller use, the adherence information, overuse of the rescue, patient perception of asthma control, or none of the above? And again, this kind of goes back to that debate we were having earlier, but this is, now that we've seen the report, seen the data, what do you think would be the most important information in your practice? So we'll launch the poll. Give everybody a moment to respond. This one really is tough. It's looking like it's going to be a split decision, sort of like our election these days.
Yeah.
Just one more second.
2 presidents.
Not sure how that would work out. Definitely not these two.
Not these two, eh?
Yeah. All right, we're going to go ahead and close the poll and share the results. So it looks like first, overuse of rescue, and controller adherence information almost tied, right? And up until the very last minute, those two were 50-50. That's what I was laughing about. And then inhaler technique at 14% and patient perception of asthma control at 7%.
That's great.
So it's really nice to see.
Yeah, it's interesting.
Mm-hmm.
Any thoughts from the panel about that feedback?
Yeah,
I think it makes sense to me. You know, I mean, controller and preventative medicine always, you know, tends to make the most logical sense. And then, of course, for all the reasons we described before, the rescue inhaler information, I'm not surprised is a close second, you know, but ideally, I think all of the above, right, we would want to know in any report.
Vic?
Agree. I think consistent with what we were saying is both, I mean, kind of equally important or in different ways, and that's suggested in the polling data as well. They're just, it's a hard decision, and exactly, fortunately, you don't have to choose, so good.
Yeah,
absolutely. All right, go to the next slide. I think we've got another question here. In your opinion, what do you feel is the most problematic aspect of Elizabeth's case? So we will launch that poll. Is it the poorly reversible lung disease, adherence that is suboptimal, decay in her inhaler technique, or her poor perception of asthma symptoms, or do you think it's something else? Give everybody a few moments to answer here. Again,
I think if we asked Elizabeth, she may have a different opinion than we have.
yeah.
Right.
I think none of the above might be her answer.
Or holding on Wednesday night is difficult.
She would say, I'm fine, I'm fine.
Yeah.
Yeah.
All right, we've got about 2/3 responding. We'll give it just another second and then we'll close the poll and share the results. So,
Very interesting.
Ray, you want to cover these?
So pretty clearly the adherence being suboptimal was what the vast majority, 64%, felt was the most important problematic issue for Elizabeth. Again, what she might have answered could have been totally different. 25% patients poor perception of her asthma symptoms, and the rest were only 4% for poorly reversible lung disease, DK and inhaler technique, and none of the above. Again, I think something that we need to keep in mind, though, is that there are multiple studies that show that patient technique decays with time in the vast majority of patients. We're not really sure exactly why, but it is something that for years and years in our clinic, up until the point where we got to COVID, where everybody's wearing masks and we're not actually doing what we did before, but we used to give people placebo inhaler when we had placebo inhalers, and they had to demonstrate with or without a narrow chamber exactly how they were doing it with teach back to my medical assistants or nurses every single visit, every single time, and we would document it. You can't really do that quite anymore. So this is a really nice surrogate way to do it in real time over the whole period of time in between maybe 3-month visits. So I find that interesting that the DK and inhaler technique was not felt to be as important as some of the others. But
all right, our next poll, we've got 2 more as we're coming up on time. If this patient is being considered for escalation of therapy, how important would a digital inhaler report be in tracking her asthma control before escalating therapy? Not important, slightly important, moderately, or very important? Again, we're considering stepping her up. So
How important would it be to convince her that she needs to step up?
yeah,
As always.
it would be that back and forth, I think. It sounds like
Yeah.
Elizabeth is certainly not 100% on board with the treatment plan, right? All right, we'll go ahead and close this poll and share the results. And it looks like, again, universally, we feel like very important and moderately important to have that data.
And Tanya, don't you think from a patient's point of view, this would really help if you had this data and shared decision-making, especially about advancing therapy, that you can go over with them and they feel like they're self-directing their care to a degree and have control.
Yeah, I mean, I think that that's the point, right? Because so many times there is that disconnect, like, well, I think I'm taking it and I think I'm taking it correctly, and why should I step up or do it more frequently? And so now we've got some objective data that really does help to make that case, and also to consider, is this really working? And share again that if you're not, a third of the time she wasn't doing it correctly, right? So I think that it's obviously an opportunity for that education and greater awareness on behalf of the patient around proper technique.
so any final thoughts from the panelists?
Yeah, I think as we touched upon, those reports really are exciting. I mean, and they're not seen before, and I think the opportunity to review that with Elizabeth is really is objective. It lends itself very nicely to shared thinking to kind of just show her what the facts are, how much used her rescue inhaler that day, and kind of get her take on it, and then provide solutions from there.
So we do have a couple of questions, and I'm sorry, Pravia, I just wanted to get to some of these questions because I know that people will want the response. So some of these I think are very relevant that you all will be able to address. So one, did the devices send like an alert when either to the patient or to the physician if the rescue or quick relief is being used too frequently? Can you actually program it or put an alert mechanism in place?
My knowledge is I don't believe so. I think the only alert is that it shows on your graph, if you look at your app, that you've used it that many times with the little red star, and I don't think there's any auditory alert or anything to my knowledge.
No reminder or anything. No.
Yeah, I don't think so.
Okay. That would be helpful for future, development of the app.
Yep.
Yeah.
And then another question around affordability and insurance coverage of these devices. Anyone could speak to their own experience in affordability and insurance coverage.
Gosh, they're so new. I'm not really 100% sure. I think that would have to be, I'm sure that depends on the area of the country that you're in and what, I know that there would be coupons available, promotional coupons.
And a prior auth is probably going to be necessary.
Yeah, and when I think about this, I alluded to it earlier, I'm not sure that this is right for like every single patient, right? Because definitely there is a higher cost due to the technology, and there also is a higher burden on behalf of the physician and the patient. So I'm not sure that it would be appropriate for every single asthma patient. But I definitely think that when we're talking about those step up patients, or we're talking about those patients that are post-discharge, or maybe that a patient that's had a couple of bursts of oral steroids in the past year, like this would be really valuable.
Or the underserved. Patients with access difficulties, the underserved populations are inner city, maybe rural populations. This gives us access kind of into what's happening with those patients. And traditionally, those are the ones that have the poorest adherence and inhaler technique. And so there's problems. We know COVID has just highlighted these problems with healthcare disparities. And so this is a way to kind of ameliorate those to a degree.
So I stand corrected, the SABA does have overuse notification ability. And apparently the controller has reminders to take your medicine.
Right.
Obviously, she doesn't
wonderful.
always listen to her reminders, but
I think you have to activate those.
I'm sure, just like you have to activate your audio and your video here when you,
And I think to the affordability piece, it doesn't directly answer it, but you could certainly make the case that it's more cost effective or benefits the system more than stepping up to a biologic agent, for example, and somebody that might just be not compliant with their controller medications or using it the right way.
And that's going to be really the future. The future of telemedicine and digital health is going to be really making sure there's a good usability, personalization of each of these things, and in the hope that you're going to engage the patient better and really get them on board with what both of you decide you want to do. So I think it's got a bright future, and it's certainly, we're starting to see with telemedicine that these technologies do have a future.
Well, we've got just another moment or two. So any final comments from the panelists before we close out this evening?
I would just like to say this was a fun hour for me to hear everybody commenting about this case. And I hope that the Allergy and Asthma Network attendees, participants, people who signed in feel like they found this to be valuable to them. This whole concept is again, after 38 years for me in private practice, is exciting. Yeah. So thank you, everybody.
Absolutely.
Thank you.
I echo from the patient perspective. I mean, I think that this is an exciting time where we can leverage tools and technology to impact adherence and outcomes and make sure that patients are getting the right treatment at the right time, and also helping to ensure that we are stepping up and stepping down appropriately. So again, I think it's a great tool in conjunction with telehealth to continue to advance. I am so grateful to Dr. Davis as the facilitator of this evening's PBL, as well as to Dr. Tejwani, Dr. Parikh, and Dr. Buckstein. And once again, want to thank Teva for their support of this evening. And we will make this available on our website at allergyasthmanetwork.org, our webinars, for archive viewing. So please, if you would like to revisit it at any time, please do so. And then again, we'll be doing a follow-up survey after this evening to just get your feedback and make sure that this met your needs and what you learned, and how we can continue to improve these programs. So thanks everyone, and hope you have a wonderful evening.
Perfect. Thank you all.
Thank you, everybody.
Thank you.